Germline PVs were found more frequently in individuals with upper tract urothelial cancers, and that's consistent with other studies which have shown a similar finding. However, there were no other statistically significant differences between the two groups in terms of demographics or clinical characteristics or family history. And as a gent counselor, I was most interested in that family history data. The data that we had available to us through the Orion data set was a bit more limited. And we generally classified the two groups as having family history of cancer in close relatives versus not. However, so it is possible that with more detailed family history information, we maybe could have seen, some type of difference in the strength of family history or type of cancers. However, the family history information that we had was abstracted from the medical record and is generally, reflective of the type of information that is collected during routine clinical care. So, I think, it is certainly possible that we missed a possible association with family history and pathogenic variants, but, our study, along with many other studies, have found that family history is not necessarily adequate for identifying all patients who might have underlying germline PVs.
This is interesting. Bladder is the most common site of urothelial cancer. Only a minority of patients present with disease in the upper tract or in the urethra. And so a comprehensive germline panel test could identify inherited cancer syndromes in these small subset of patients who have non-bladder primary sites.
So, and as we've brought up, Lynch syndrome is the hereditary condition that is most strongly associated with a risk for urothelial cancer risk. However, in our data set, 60% of the mutations were in homologous recombination repair genes. Another 19% were in genes in other pathways, and then 19% were in the mismatch repair genes. So, really, Lynch syndrome was a minority of the genetic findings amongst those with actionable pathogenic variants. And, while our analysis was not designed to show that those other genes necessarily have an increased risk, once again, as Dr. Gupta mentioned, other studies have shown similar findings that there are many different genes that, that may be playing a role in these patients or that they may harbor pathogenic variants in. And so, this idea that, using microsatellite instability or family history of Lynch syndrome related cancers, as being our primary way of identifying the people who would benefit from genetic testing, is really going to miss a majority of the people who have actionable germline variants. So I think this was really, further evidence that we need to think broadly and also test more broadly in these patients.
Our study shows that if we were to focus on patients that have non-bladder primary sites of disease and perform comprehensive panel testing, we may identify a clinically actionable inherited risk in 11% of patients.
I think that our findings do support that some of these patients do warrant germline genetic testing, and that will be increasingly indicated for them. As a gent counselor, I feel like this is one of so many studies indicating that the prevalence of germline pathogenic variants in cancer patients is higher than we had previously realized, and that we need to be testing more broadly. I think Dr. Gupta will speak to some more of our future research goals in urothelial cancer specifically. But, as a joint counselor, I feel like this is, further evidence that we need to pair these types of studies along with other more implementation science projects about how we can develop automated tools, both to help us identify patients who are being diagnosed with these cancers that warrant genetic testing, that we have resources for efficiently and effectively reaching out to them and offering germline genetic testing. This is just expanding the scope of patients that this applies to. And at the Huntsman Cancer Institute, we do have several other studies going on along with this type of research to really look at that implementation piece. And I think that's really such an important area and focus to go along with all of these other studies in order to really put it into action. We need tools to get genetic counseling and testing to these patients.
In terms of further study, we continue to analyze the growing Orion dataset. We are looking to identify novel germline variants associated with urethral, or rather urothelial cancer susceptibility. We are exploring the role of the germline makeup in tumor biology. And we are putting together germline molecular as well as tumor molecular data along with clinical disease scores to help find more precise and personalized treatment for urothelial cancer.